we would expect to see arthritis and degenerative and like, okay, I get arthritis in my right ankle, right? Okay, where would be the next place that I would develop arthritis? If I get it in my right ankle, if it's degenerative, where's the next place that I would compensate to take up for weakness in my right ankle?
Your left ankle?
Yeah, a left ankle or right knee. Does that make sense?
Yeah.
So in a concentric circle, you're going to move away from that joint. So I would start to see arthritis in my toes and the arch of my foot, my right knee, and then over like you're right in my right ankle, and then left ankle and then left knee. So as the body starts to compensate for weakness in one area, the other joints start to take up that slack or take up that pressure, that trauma, and then those will start to degenerate as well. So excellent. So number A is probably rheumatoid. So is that an accept?
No.
Okay, let's look at the next one.
Genetic predisposition for joint inflammation.
So what's that one?
I think it's still rheumatoid.
Yep, genetics the key word there, right? Because it's autoimmune. So they may already have the genetics for it, and then autoimmune diseases come because they just respond to a stimulus, right? They may have breathed in a particle, or they may have exposed to a toxin, or maybe it's the bad air in Utah. Any number of things causes this to trigger, and then it's the genetics then kick in, and they develop this arthritis. Good. Okay, what's the next one?
Damage to the cartilage resulting in loss of joint padding through overuse.
Okay, what's this bad guy right here?
That would be degenerative.
Okay, and why is that one degenerative?
It's just being worn down from aging.
Yep. The key word being overuse, right? It gives it away right there. Overuse by definition is degenerative or use-based arthritis. And the last one?
Can be treated with infliximab, and I think that's right because it says MAB drugs in there for the...
Yeah, and MAB drugs those are the targeted drugs for autoimmune and cancer stuff, right? That's by definition what they do. Awesome. So the answer to this one is C. That's the accept. That one only is associated with degenerative arthritis, and the other three are associated with rheumatoid arthritis. So when in doubt, the one that's not like the other ones is the answer.
All right.
Okay. Number 3, a man with arthritis has taken the maximum dose of aspirin and ibuprofen for 2 years. Which of the following adverse side effects could be expected? So aspirin and ibuprofen are called what? What are those? There's a general term for those kinds of medications that people take.
NSAIDs.
NSAIDs. There it is. Hala said it. So NSAIDs, non-steroidal anti-inflammatory drugs, and that's ibuprofen and aspirin. Okay. So let's talk about what the deal is. So loss of appetite. Would you get that from chronic use of NSAIDs?
I don't think so.
Well, no, yeah, these guys have been taking these for 2 years. So if he's had any depression and appetite, he would have had it way sooner than now, right? So just through time, if he lost his appetite, it would have been a long time ago, and now his body's adjusted to the aspirin and the ibuprofen, and so now his appetite's probably returned to relatively normal, or whatever normal would be while he's taking the NSAIDs, right? Okay, positive occult fecal blood test. What's going on here?
I don't think that would happen.
Okay, and this one I had to have someone tell me because I thought it was C, gastric pain immediately after taking medication, and then prone to frequent infections. And the reason it's B, because Hala fixed me and some other people fixed me when they saw the answer that I originally had for this one. So it's B, positive occult fecal blood test. And the reason that it's B is because aspirin and ibuprofen irritate the stomach and the intestines, and chronic use of this is going to cause ulcers in the stomach. And then the ulcers in the stomach, the bleeding in the stomach is going to travel down system from the stomach to the intestines and then ultimately to the anus and then out through the colon, and it's going to be pooped out. So that's why they're going to have a positive occult fecal blood test. And for number 3, it would be B. Okay, we good? Paul, you want to take number 4?
Yeah. A 20-year-old college student injured his ankle while playing soccer. The ankle becomes red, swollen, and cannot bear weight. After taking x-ray, the physician tells the patient there are no broken bones and he has a sprain or strain. Which statement correct?
Okay, so this one here is a little tricky on how it's worded. So what kind of injuries are they actually talking about here? Are we talking about bones being broken, or are we talking about a soft tissue injury?
No. This is basically we're talking about tendons and ligaments, which is soft.
Yep, these
But
are
it's
soft
not
tissue based.
muscle.
These, yep, soft tissue based. So let's look at it. It tells us what they are right here. It says, hey, they X-rayed the patient and there's no broken bones. So now we know it's soft tissue based, and they basically tell you that this person's suffering from a strain and a sprain. So when we talk about strains and sprains, what's the key information that we need to know about strains and sprains?
Strain has a T, tendon has a T.
So. Yep, that's tendon based, and then sprain would be
is the tendon
ligament based.
Yeah, ligament based.
Yep. So strain is tendon based, and ligaments are associated with sprains. Now let's ask ourselves. So a ligament. So how is a ligament bone to bone attachment or muscle to bone attachment?
Ligament is a bone to bone. Tendon is muscle to bone.
Okay, so that's yep. So tendon is bone to bone, and ligament.
No, ligament is bone to bone. Tendon is muscle to bone.
Let me hold on. Anterior cruciate ligament. Yep. So again, the only reason I can remember what a tendon and a ligament do is I just remember that the anterior and posterior cruciate ligaments in the knee, they're two of the two ligaments inside the knee that attach the tibia and the femur together on the inside of the knee, and they're damaged really easily. So those are bone to bone. So anterior cruciate ligament is bone to bone because those, and I just remember that one, and now I know all ligaments are bone to bone. And then tendon or muscle to bone. And the tendon in that region, the patellar tendon, attaches the quadriceps to the tibia. It goes across the patella and attaches down at the tibia, and that's the ligament. Okay, so that's explaining what a sprain and strain is, kind of how they work. So it says, which is correct? So it says A. Oh, sorry, go ahead, Holly. You were reading this one.
You're welcome. Okay, so A is a sprain is due to a tear in muscle or tendon, while a strain is a tear into a joint capsule. It's wrong.
Why is that one wrong?
Because a sprain due to a tear of muscle, no, it's not. It's a tear of tendon.
Yeah, well, no, and so again, a lot of times strains and sprains, those are not tears. Those are acute. They reduce on their own, right? We do rest, ice, compression, elevation, RICE. And then we bandage them up a little bit, and over time these heal themselves. They don't need any intervention. Where tears, those need intervention. We need to fix those. Okay, keep going.
And here, so A is not correct. B says a sprain is associated with a microhemorrhaging. A strain is minimal to no bleeding. Well, no, it's wrong. It's again wrong. Because a sprain associated with microhemorrhaging, no, it's not. It's just it makes it swelling. There's no bleeding involved.
So let me ask Ashley.
Let me tell you exactly what's happening here.
Go ahead.
Our tendon and ligament is not vascularized and it's not innervated. So when they tear, there is no bleeding involved because there is no vascularization inside of a tendon or ligament. So hemorrhaging is bullshit because it's not good. If there's no vein, how can you have bleed?
So hemorrhaging is associated with bruising, right?
Hemorrhaging.
If we have hemorrhaging with impact, hemorrhaging with trauma is bruising, right? It's contusion, it's bruising based. And are we going? And I think you're right on target, Hala. We're not going to have a lot of bruising in a tendon or a sprain or a strain, right? We can get it if there's impact, but if someone just stepped funny on a piece of unequal concrete and they strained their ankle, there isn't going to be a lot of bruising. There's going to be a lot of swelling. They'll get a lot of fluid collection there in response to that trauma, but there's usually not that much bleeding associated with it or bruising. And so, yeah, any talk of bruising and hemorrhaging and blood collection with strains and sprains, unless there's another force causing blood vessels to break in that soft tissue, we shouldn't see a lot of that.
And C says a strain is characterized by sign of acute inflammation, while a sprain is chronic in nature. They both are acute. When you injure it, you swell. So not one. There's no chronic. It's acute. Both of them are acute. You get injured, you swell. That's how it works. So that's wrong too. The last one is a sprain is due to a tear into ligament, which is correct. And a strain is due to injury to muscle or tendon, TNT. Still correct. So D is the correct answer.
Yeah, and I don't like how they worded the first piece of this. This is a strain is due to a tear in the ligament. It would read better if it said a strain is due to an injury in the ligament, and while a strain is due to an injury in the muscle or tendon. But whatever, the test writer chose to say tears.
You can tear your ligaments.
Yeah, no, the reason I don't like it is because when you tear these, they don't repair themselves easily when they're torn.
They have to go surgery, yeah.
Actually repair themselves because they're not physically torn. But when we tear them, they don't repair well. And so we have to go in and fix them. And I don't, yeah, it's just, I learned these in a different class, in a sports injury class. And there was a little bit more nuance to it, but that's fine for the here and now.
Okay.
The correct answer is D, right? Sprain is due to a tear in a ligament, while a strain is due to a tear in the muscle or tendon. We good?
Yeah.
Okay, Ashley, you want to take number 5?
Yeah. The Gower sign for assessing Duchenne muscular dystrophy can be elicited by having a patient do which of the following? I haven't read up on this one yet.
Okay.
So
No, we'll talk through it.
Okay. Rise from a squatting position to a standing position. Hop on one foot and then the other. Bend from the waist to touch the toes. Close the eyes and touch the nose with alternating index fingers.
Let me ask you a question. Have you ever heard of any of these other, when you look at the answers, have you ever heard any of those tests being used?
No.
Oh, Hala just dropped out. Okay, I don't know what's going on with that. Okay, so yeah, you have number D. Read number D out loud again and ask yourself, when the policeman's pulling someone over on the side of the road, what do they have them do?
We do that for a DUI.
Yeah, and what are they testing for when they have someone do that? They're testing what function?
Cognitive, maybe?
Yeah, they're testing neurologic function, right? Cognitive function. They're testing the alcohol's permeation of the blood-brain barrier. Remember, we talked about in class how the blood-brain barrier can be permeated through the alcohol can go through the blood-brain barrier freely, and there's nothing stopping it. And that's what's happening. So number D is clearly not the right test, correct? Because it's testing something entirely different. So let's look at this one here. Bend from the waist to touch the toes. Have you heard of that one before?
No, I don't think so.
Yeah, we have. You do that in yoga class. When you do that, you're testing for back extension. You're checking for flexibility in your back and your back muscles. That's what we're testing for. It's a flexibility test. And that's got nothing to do with muscular dystrophy. That's flexibility, because muscular dystrophy is something else. So let's talk about B. Have you heard of B before?
No.
Well, no, B
Maybe for kid, I don't know.
B is an agility test, right? You're testing for developmental ability for muscular skeletal development in children, right? We do that for kids. And then people who've been injured, right? When somebody hurts their foot, their leg, we do these things to test their strength and their agility to see if they're getting normal agility back. Now, Grower's sign for addressing Duchenne muscular dystrophy can be elicited by having a patient do the following, okay? So let me ask you a question. Do you actually know, just generally, what's muscular dystrophy? Have you heard of that before?
Isn't it like your muscles degenerating? It's like a...
Well, let's look at them. Let's look. Remember how I'm a big I'm a huge fan of medical terminology. So let's look at, so Duchenne's someone's name, right? That's just somebody whose name that is. That's the doctor, whoever addressed this. But muscular has to do with the muscular system, right? We'll break down dystrophy. What's dys mean?
Is it abnormal?
Yeah, abnormal or painful, right? And trophy means what? What's trophy?
Is it growth or shrinking?
Yeah, shrinking of size, right? So if it's muscular dystrophy, then it's muscular abnormal muscle loss, right? We're losing muscle in a weird way. And then Gower's sign, Gower sign is when a person with muscular dystrophy gets up off the ground when they're laying down. They actually turn over onto their, like you and I, we have strength in our stomach and our back. We can lift our torso up, right? Bring our feet up underneath us with their hands balancing us, and then we just stand up normally and go. But people with muscular dystrophy, because they're losing strength in their back and in their torso, what happens is they learn to roll over on their stomach, and then they compensate for loss of muscle strength in their back and their stomach by actually getting on their, like bringing their feet underneath them as best they can, and they use their hands to walk themselves up to a standing position, kind of like that upward facing dog stuff in yoga. So they use their hands to walk their hands to their feet, and then from there, now they're standing up, and then they use their hands up their legs to bring their torso up to standing so they can walk. And they call that Gower sign.
All right.
So that's a little bit of a preview for you, because you're going to be obviously reading into this section, but a little bit of a preview, okay?
Okay.
So that's what Gower sign is. And then just know that muscular dystrophy itself, by definition from the book and the notes, is when muscle cells are degenerated from muscular dystrophy. What happens is the muscle tissue itself, instead of it being replaced with more muscle tissue, it's replaced with fat and like collagen. Other connective tissues replace them. And so they lose the ability to contract. So you still have connective tissue holding your body together. That's why people with muscular dystrophy just don't start losing limbs, right? Their limbs just don't fall off, because the connective tissue, the muscle tissue, is degraded and replaced by collagen and fat cells. And so that's why they don't waste away. But their stature, they lose the ability to stand up straight. They lose the ability to walk normally. Their gait is going to be disrupted, and they lose the ability to lift and to manipulate things with their hands and arms. As the disease progresses and lose more and more muscle tissue, they just become more and more and more immobile. Okay, we good?
Yeah.
Okay, that's just a little bit of a little heads up. Yeah, muscular dystrophy is a little bit more of the complex. Some of the other things we've talked about are pretty straightforward, like you've probably heard of them before, right? Just from normal.
Yeah.
Just from normal being alive and having kids and being in nursing and basic anatomy and physiology. Some of this stuff is just intuitive, right? You just, oh yeah, that makes sense. Muscular dystrophy is a little bit weird because it's not intuitive, right? You have to have some exposure to it. And I just happen to have already read the notes. All right. So that's why I'm a little bit more spun up on it than you are. It says, which of the following factors may adversely affect bone healing and therefore place the client at risk for long-term problems? Okay, so let's ask ourselves, do you know the process of bone healing? When you break a bone, what's the steps and process for bone healing and bone regrowth?
I think the first one is like hematoma forms. Yeah,
there's hematoma, right? We draw blood and tissue and swelling to that spot, right? And that's to protect it and to start to bring nutrients and like building blocks there to start to repair this thing. Do you know what the next part is?
Then you do like a callus.
Yep, there's a callus. Yep, a pre-callus and then a large callus and then a regular callus. And then what happens? That's basically the middle steps. And what's the last step?
Ossification.
Yeah, ossification, and then the last step is bone remodeling, right? Like normal process of bone remodeling starts to happen to remove the callus and to start to lay down good strong bone as you start putting more pressure on it and start to use that bone. Those are kind of the steps. Perfect. Awesome. So it says, which of the following
stronger after?
So it can develop stronger, but how does so say for instance you broke your tib and your fib, right? Your tibia and fibia. So what are you going to lose in order for that bone to be really, really strong? What makes our bones really, really strong?
I don't know, calcium.
No, not calcium per se. Weight. The reasons that our bones are strong in a certain way is weight. Well, if you had your leg in a cast for 6 weeks and you've been in a wheelchair or lying in bed, what is all of your muscles and body going to be like?
You're going to be losing your muscle mass.
You're going to lose muscle mass and bone density in the directional forces or the torsion forces that you apply on those bones in your leg. Not only in the leg that was broken, but in the leg that was favored, right? Because you're going to want to be putting all your weight on there, but you're going to be in a wheelchair, you're going to be on crutches, And so so they're both going to be a little bit degraded over when you started. And then how do you get that damaged leg to build up bone mass again after the injury? Well, first of all, the doctor's going to remove the cast, right? What is he going to tell you when he removes the cast?
I don't know. I've never broken anything.
He's going to say, well, you've known people with casts on. They take the cast off, and what does the doctor say? Start using that. Right?
Oh.
They don't tell you to stay in bed longer. They say, hey, listen, we're taking the cast off because this is healed. We want you to get out and start moving around. Now, they're going to say, hey, don't get crazy. But they're going to say, hey, we want you to go to the mall and start walking around three times a week because you've been doing nothing. Hey, we know that before your injury, you really liked rock climbing. Hey, get out and start rock climbing maybe 1 or 2 days a week. Start to put some mojo on that bone and on that leg. And so they're going to have you get up and start moving around. And that right there, because you're putting pressure on that bone, that's going to cause the remodeling. And absolutely, if you start getting on it, then that calloused part, and because there's a lot of nutrients and calcium being drawn to that spot anyway, it can certainly develop and become a little bit stronger than before the injury. But remember, anytime after repair, that usually isn't as good because now you've got, fibrous tissue that wasn't normally there, and that can diminish function.
Mm-hmm.
Okay, so it says, which of the following factors may adversely affect bone healing and therefore place the client at risk for long-term problems? Select all that apply on this one. So let's go through these and we'll talk about them. Now that we kind of know what's going on with bone healing, let's talk about each one and figure out which ones apply.
Okay.
You want to read A?
Yeah.
Go for it.
Presence of a large hematoma that prevents union of fractured bone ends.
Would that be a problem?
Be bad if it prevents union.
Yep. You got a massive hematoma in between the two broken bones. It's going to absolutely prevent those bones from wanting to rejoin. So that's clearly one of the things that was going to be a problem.
Yes.
Let's look at B.
Use of fiberglass casting material and traction apparatus. I think that's okay.
Yeah, use of fiberglass casting material. We do that all the time. And when we apply traction to every damaged bone, the traction's process is to straighten the bone. We apply negative traction on it. It pulls that bone out of the broken position and realigns it. And it also releases any soft tissue that may have collected around it that's grabbed onto it. Like muscles want to grab onto those broken bones. We apply traction. It allows those muscles to relax and release the bone. And then it allows it to slip back in place and realign. And then we apply a fiberglass cast and allow it to heal. So that's clearly a normal process and something that we want to put on someone's broken bones. Let's talk about C. C is a really fun one. I like C.
Hypoparathyroidism related to recent thyroidectomy surgery.
So this one's harkening back to the endocrine system, right? Our endocrine lecture. So what's going on? The parathyroid does what in the body? What's its major function?
I don't know. I'm brain dead right now.
It regulates calcium in the body.
Oh, okay. So
remember, it regulates calcium. So if that's been damaged and you're in a hypo or low parathyroid function, causing there to be a limited amount of calcium to be available due to a thyroidectomy where they removed the thyroid, is that going to be good for bone healing or bad for bone healing?
Bad.
It's bad, right? Because now the calcium that we need for bone healing isn't available to help to rebuild that calcified mineral component of the bone. So that's clearly going to cause a long-term problem. Okay, so history of circulatory problems caused by diabetes mellitus.
I think that's bad too, because you kind of need that circulation too.
Yep, you're gonna need that circulation to bring all that calcium. And so again, traditionally in like long bones and stuff like your femur, tib fib, humerus, ulna, radius, those bones aren't as affected by this as much. But what if you had a broken finger or a broken toe and you were diabetes? Would that be more of a significant issue to those?
Yeah.
Yeah, because those ones don't like those. Remember those sores that people get that don't heal anyway. So yeah, and those definitely a bigger issue with those smaller bone breaks further out. But yeah, anytime you have impaired circulation, it's going to cause problems. Okay. E, infection of the bone or tissue at the fracture site.
Yeah, that's probably not good.
That's probably a bad thing. That's actually by definition osteomyelitis. Osteomyelitis is an infection of the bone tissue. And yeah, that's going to cause issues. And that's going to cause issues you don't even have broken bone.
Yeah.
Okay. Long-term steroid use.
I don't really know the effects of that on bone, so
Yeah, this one I'm a little bit sketchy on, but let me ask you this question. So who already has issues with bone growth between men and women?
Isn't it women?
Yeah, women are already predisposed to have a lower bone mass than men. And so I read something, not in this class, but back when I was doing my first degree in sports medicine, young women who are athletes who are using steroids sometimes have some issues with some of this because the steroids, again, will interfere with bone mass development. And don't quote me on that one. So F is the one that I'm out there on still, but I'm pretty sure long-term steroid use, especially with adolescents and youth athletes, is going to cause some pretty significant issues with their bone development long-term. And so that's what they're talking about, long-term problems. So again, number F, don't quote me on that one. I'm going to look at the textbook on this one to see if it's in the textbook. It's not in the notes that they gave us. Okay. But I did read something somewhere before where steroid use in young athletes specifically is not good for bone development.
Yeah. Like I know it's not good for your body in general, but I can't think of how it would affect the bones.
Yeah. So there we go. So Mr. Simmons is returning to the clinic for a follow-up after a recent knee surgery. Excuse me. Upon assessment, the nurse notices several indications that the patient has developed osteomyelitis. Maybe it's osteomyelitis that's the bone infection, because there it is. Select all that apply to this condition. There is pus-looking drainage from the incision.
Yes.
Yeah, that's gonna be a definite indicator that there's osteomyelitis going on and there's something bad, right? They had their knee worked on and there's pus physically coming out of the incision sites on that knee injury. Okay. The client's right leg looks pale and cool.
I don't think so.
Yeah, that one I'm out on that one. I got to ask Tana and Megan on that one because again, what is pale and cool? So it's the right knee, right? So what would cause the patient to be right in the right lower leg to be pale and cool?
Isn't it like right heart failure or something like that?
Well, compartment syndrome. In musculoskeletal injuries, compartment syndrome causes the extremity to be pale and cool because we've either constricted it, right? We've actually put a bandage around an area above that spot to control bleeding and to control the bone breaks and the damage. So if we put them too tight, it can cause that compartment syndrome, and that's when you're going to get a pale and cool limb because you've physically occluded blood supply. You've constricted it to the point where the blood supply can't get down there, and that's when you're going to have pale and cool skin because there's no oxygenated blood down there. So I don't think that has to do with osteomyelitis. I think that has to do with compartment syndrome. And this patient doesn't have compartment syndrome. They had a right knee surgery, and now they're coming back, right? So clearly all the bandages and everything are off their knee. They're not going to have, they shouldn't have compartment syndrome. Now, if they have compartment syndrome, in this case, due to the infection, they could get compartment syndrome. It's just not as common.
Right.
I mean, it does happen. Compartment syndrome is a lot more common in like bone breaks where we have constricted it, when a cast is on it, or when there's been a complete, what's called a circumferential burn, where a burn has gone completely around the limb. Then the swelling from a burn can cause it to occlude the blood supply to the lower limb. But again, I've never heard of it where it was a knee replacement or a surgery-based occlusion. But that's not saying I couldn't be wrong. And I got to look at the notes and stuff on this. But I did look at the notes, and I couldn't find it where it said this. So I'm not sure on that one. That's an unknown. That would be a gray. And on my other notes, it's gray because I'm not sure on that one. I'm going to ask Megan and Tana on that one. Yeah. Okay, Mr. Simon reports he has chills.
Isn't that part of an infection?
Yep, that would be one of them. He's got osteomyelitis, which is an infection. So, yep, he's got some fever and some chills. So that's certainly one of them. He suddenly has dyspnea and chest pain, difficulty breathing and chest pain.
Possibly. I don't know.
What was that?
I don't think so.
No, because dyspnea and chest pain has to do with fat embolisms, right? And fat embolisms are more associated with femur and pelvis breaks and pelvis repair. That's releasing those fat molecules, those fat cells into the bloodstream, and then those travel up into the lungs and into the heart and cause embolisms up there and edema there. So we're going to see dyspnea and chest pain more with a fat embolism. So I don't think D is one of them. And then test results indicates that the patient has osteopenia. What's osteopenia? And this one here, you can break it down and figure it out.
Tiny penis. Just kidding.
That'd be apenia.
Is it loss of bone density or something like that?
Well, this one here, I think, is loss of like oxygen to the bones, because osteo means bone, and penia, right, is like air. Let's look that one up in the notes.
Okay.
Give me 1 second. I gotta take my headphones off. I'll be right back.
You're fine.
Okay. I'm back. So let's dig into this one, because I think that is one of them. And I read it in the notes. That's why I want to look it up again, because it doesn't sound familiar again. The ones that I've answered, they should be pretty familiar, but that answer is not familiar to me now, and I want to make sure that we'll check it. So osteopenia, where's it at? Lupus, muscular dystrophy, osteoarthritis. What was that?
Page 5 at the bottom.
Okay, yeah, getting there. Refers to bone density that is lower than normal peak. So is it going to be that one?
Honestly, it could be. If they just got knee surgery, they're probably not walking around on it.
Well, let's read it. It refers to bone density that's lower than normal peak density, but not low enough to be classified as osteoporosis. So this is chronic. This is the beginning stages of osteoporosis. So that's going to happen over a long period of time.
Then I would say no.
Yeah, no, that's not going to be this guy. So that's going to be leading to osteoporosis. So we're expecting to see that in an older lady or an older woman, not so much a young guy that's gotten knee replacement. Not saying that it couldn't be him, but not knowing his age and a little bit more about his condition, it's going to be a little bit more. It's going to be weirder. Okay, so let's move on. We've done like 7 of these, 8 of these. Okay, so I would just encourage you to start looking over those notes and getting into this. And then what I'm going to do is I'm going to switch gears. I'm going to bring up the reproductive stuff because we only got about 15 minutes. And we're going to do what I like to call rapid fire review.
Okay.
We're going to do this rapid fire style. So I'm going to, okay, you're up. Okay, it's up on the notes. Sweet. It's up on the screen. Sweet. Okay, so here we go. So as quickly as possible, you're going to go through these, and I'm going to help you, but I want you to go through these as quickly as you can. And if you don't remember something, you don't remember it. But let's just move through as many of these as we can, as quickly as we can, and go through them. Ready? Go.
I'm supposed to go right now?
No, I'm saying I got this up. So under female reproductive system, so go ahead and just do as many of these as you can do as quickly as you can.
And what am I supposed to do? Just read them off, or?
Yeah, so menstruation, right? You know what menstruation is?
Yes.
Okay, over here are the definitions. Do you know what any of these definitions mean?
Yes, so I can't remember leiomyoma right now, though, for whatever reason.
Okay, that's okay. So let's hit these. Premenstrual syndrome, what's that?
Premenstrual syndrome. I don't know. It doesn't even sound bad.
Premenstrual syndrome is what you get when you start to menstruate, right? Couple days before, and then through menstruation. That's premenstrual syndrome. PMS.
Menstrual cycle.
Okay, menopause. What's menopause?
Cease of menses.
Yep, you stop menstruating, right? And that means it's also the other piece that has hormonal resistance. The reason that you stop menstruating is that the hormones that normally cause the uterus and the ovaries to respond become resistant to it. They don't respond to LH and FSH anymore. So that's when menopause starts. Okay. Ovarian cysts. What do you remember about this guy?
They hurt like hell.
Hurt like hell. Okay. What is an ovarian cyst?
Isn't it an egg that kind of doesn't get released and it just sticks in your ovaries or something?
Yeah, exactly. It's one egg that normally ovulated, right? It normally got started. Everything was working great. For whatever reason, it didn't detach like it was supposed to. And so it gets a fluid-filled sac around it, and it stays attached to the ovary. Okay. Yeah. Is this reduced on its own, or do we have to do anything for this one?
Usually it just goes away by itself.
Yep. Usually the body recognizes a little bit of a problem. It goes in there and breaks that sac down. It releases that egg and gets rid of it, through normal processes. And then you go back to normal the next month. What about polycystic ovarian syndrome, though? That's a little bit different, right?
Yes.
What's going on with that guy? Or girl, as the case may be, because we're talking about female. What's going on with this little sweetheart right here, polycystic ovarian syndrome?
It causes infertility. It gives you a beard.
Why? Why is it giving you a beard?
Because you have more male hormone than female.
Yep. Yeah. Well, you have elevated LH and FSH coming from the pituitary gland, and that's causing some stuff to happen at the ovaries, but it's also causing other things to happen. So at the ovaries, what's happening? So look at the name of it. What's the name say it is? Polycystic.
So there are a bunch of cysts on the ovaries?
Yeah. So it's ovarian cysts right above. We talked about how one egg is not being released appropriately, but polycystic, multiple eggs are being activated for ovulation because we have elevated hormone levels, right? So maybe 9 or 10 eggs get activated, and then because there's enough hormone to get them started and get them all going, but there's not enough hormone to get them all to release from the ovaries. So now we've got all these eggs half started, and they're all attached to the ovary still, and they don't release. Okay? Pretty significant situation there. Do you think we have to intervene on this one?
Yeah.
Yeah, this one's quite a bit more significant, and if it's left untreated, it will continue to happen, and a woman will become infertile because of numbers. It's a math game, right? You only have so many viable eggs, and if you're activating 10 every time when you should only be activating 1, then over time you just run out of eggs because you run out because you activated too many of them too quickly. So that's polycystic. And then also you can probably get scar tissue and some damage to those ovaries and whatnot. Okay. So you said you didn't know what leiomyoma is, right? But what about endometriosis? What's going on with that guy?
That is the scarring of the uterus, and then it's also uterine tissues in places that it shouldn't be.
Amen. So when those hormones kick in and they come down to the uterus and say, hey, man, start to develop a blood wall and get yourself ready to be ready for fertilization, do you think that the uterine tissue on the side of the intestine knows that it's not on the side of the intestine?
No.
It doesn't know. So it starts to get that blood wall. It starts to develop that bloody lining because it thinks it's part of the uterus. It just says, okay, great. Yeah, let's get some blood buildup going on. Well, then when you guys go into PMS or, post-menstrual syndrome, and that blood starts to slough off in the uterus like normal, where's the blood that's attached to the side of the bladder and the intestine supposed to go? Where does it go?
Somewhere it shouldn't go.
Exactly. It's going to be sloughed off into the abdomen, or it's going to be sloughed off into the intestines or into the bladder, depending on where it's actually located. And either condition is not appropriate.
Yeah.
Okay, so you got endometriosis totally nailed down. Awesome. Okay, leiomyoma. Break this into 2 different words. Lyo's one and myoma's another. Myoma is a dead giveaway for what?
Isn't it like a tumor?
It's a tumor, right? Is it benign or is it cancerous?
Probably benign.
Yep, it's benign. It sounds benign because if this was malignant, if this was a malignant cancer, it'd be leiomyosarcoma or leiosarcoma. Okay, in the case of the uterus, it's going to be sarcoma because sarco traditionally means muscle, so it's muscle cancer. So this would be leiosarcoma, and that would be tissue, a malignant tumor of the uterine muscle, leiomyosarcoma. But in this case, it's just a benign tumor.
Okay.
So that's basically what it is. And depending on how severe it is, a lot of times you don't do anything for this. You have it, nothing happens, and whatnot. But it becomes the most intense when you have a tumor, you have a benign tumor inside the wall of your uterus. When would that become really, really active and be aggravated and hurt for a woman? Only be sometimes that would be really painful.
Pregnancy or
during pregnancy, you would probably, right, because that tissue is not going to respond the way normal tissue is going to respond. When else would this stuff be activated and not be very comfortable?
Probably when you're on your period.
Yeah, when you start to excrete, or that uterine wall starts to release to be pushed out through the menstrual cycle, then when that those muscles start to contract, right, your uterus contracts to push that stuff out. Yeah, this could be a little bit painful. Good, awesome. Okay, that's what I mean by rapid fire. Does that make sense? See how quickly we went through those? And if there's something about that you don't understand, then that's just a good indicator to you. Hey, man, I maybe want to go look at polycystic ovarian syndrome, right? You kind of know it now. Leiomyoma, you may want to look in the notes and look at that one again because it didn't just immediately come to you.
Yeah, I was like, awesome. I remember that.
What was that?
I was like, I don't even remember learning that one. But...
Well, and I think you're probably a little bit weary right now as well.
Yeah.
You got kids crying. You sound a little tired. It's Thanksgiving. Let's be honest. You're busy, right? You've been cooking food and shit all day.
Exactly.
So you're tired. Okay, and this is exactly the time to gauge how well you know this. If you can draw this stuff up when you're weary and tired, then you know it pretty well.
Right.
If you're tired and you're forgetting it, then again, maybe backdoor the test and make sure you're well rested for exam day. Right? I mean, be rested anyway, but does that make sense?
Yeah.
It's a good indicator. But if you can call this shit up on the day that I've been up for 20 hours and my kid's got pneumonia, and you can recall all this stuff, then guess what? How well you know it.
Yeah.
You know it pretty well. If you can't call it up when you're rested and stuff, and you're fully fed and everything's wonderful, and you're sitting in your calm house, then you probably need to look it over some more. Cool. Ready to keep going? Let's hit this. Let's do this. I'm gonna jump to male real quick, just so we don't get caught up just in the female stuff, and then we'll just keep going. Okay.
Sounds good.
Really quickly, there are 4 areas in here, and we'll hit these quick. Okay. Which one do you want to do? Penile, scrotal, cancer, or prostate disorders?
Let's do the prostate.
Okay, prostate. Let's hit these guys. So prostatitis, what's going on there?
Inflamed prostate.
Yep, that's an infection, right? It's an infected prostate. So how are we going to take care of an infected prostate?
Antibiotics.
Yeah, depending on what it is. If it's bacterial based, we're going to give it some antibiotics, try to get that to reduce and kill that bacteria, right? If it's something else, if it's viral based, can we get prostatitis from a virus?
Probably, but you can't give antibiotics for that.
Yeah, we wouldn't give it antibiotics in that case. We'd give it an antiviral, or we'd look for a different treatment for that. Okay. How is this going to present in a man who has this?
Probably pain in your lower abdomen area.
Yeah, pain in the bladder, right? Probably getting some pain around his bladder in that central, subgastric area, right? Around his bladder, around the bladder. Okay, that's going to be one. Also, guess what? It's really cool that the signs and symptoms and different pain structures in prostatitis are almost exactly the same as benign prostatic hypertrophy. They're almost exactly the same. So difficulty urinating and painful urination would be it. And also, wouldn't there be some sexual dysfunction with this?
Yeah.
There'd be some sexual discomfort and some sexual dysfunction associated with prostatitis and benign prostatic hypertrophy. They're both going to cause this. But in this one here, prostatitis, if it's bacterial viral based, there's a medication we can give for that to reduce it and bring it back to normal and bring normal function back. But in benign prostatic hypertrophy, every man is going to get benign prostatic hypertrophy. And how do we treat this guy?
This is the one that comes with just aging, right?
Yeah, every man is going to get this. The older they get, the more opportunity for this to happen. Exactly.
So just like a catheter.
Yep, catheter is the first treatment, but ultimately they're probably going to have to roto-root this guy. They're going to use a little bit more aggressive surgical procedure to open this back up, physically removing tissue. They're physically going to go and remove tissue in there to open that back up because the catheter is only a temporary opening.
Right.
Okay, and if it needs a permanent opening, they're gonna definitely go in there and they're gonna roto-root that thing out. Okay, when they roto-root this out, though, what can happen to the prostate? What can happen?
I feel like it would damage it.
Yeah, they're gonna become incontinent and they're gonna lose sexual function permanently. That they got to go in there. Now that's not saying now they like Megan talked about and Tana talked about in class that as better treating this, there are certain surgical procedures and surgeons who are getting good enough that they can relieve benign prostatic hypertrophy and not damage the prostate. The men that get it won't be losing sexual or urinary continence and function, but not all the time. There's still a chance they're going to lose sexual and urinary function.
Okay, I remember that now.
Okay, yeah. See, it's just a matter of shaking the brain, right? You're kind of warmed up now. We kind of shook in your brain a little bit and got you warmed up.
Yeah.
Cool. Okay, well, I'm going to leave you alone. It's 10:30.
Okay.
Have a good review. Okay, so get on 12. Start reviewing 9, 10, and 11. And like I said, tomorrow, since you're the only one here, I will just ask you point blank. Do you want to do a study group tomorrow in the morning or in the evening? And you can say no, I don't care, because I got family I'm trying to see and have dinner with too.
Yeah. Well, I work from 1 to 10.
Okay, that's not going to work.
So I could do morning, but that depends on if you can do it.
Here's what I told Sandra, because she's got a lot going on. If you'd like for me to do this, I work tonight from midnight to 8 in the morning. When I finish work in the morning, would you like me just to send you a text to remind you to study?
No, I think I'll remember.
Okay.
But yeah.
I will provide as much or as little support as you want over your holiday. Sandra said she'd like a text. She's like, hey man, will you remind me to get into my books tomorrow? Knowing that she couldn't study, but she said I would appreciate to be reminded, because she says I'm going to be elbows deep in turkey guts and whatever, and she said that would be nice for someone to just let me know and remind me that I need to be thinking about this.
Yeah,
but that's okay. I will, like I said, go have a very good Thanksgiving, enjoy yourself, and then on Friday I'm just going to get back to normal, like 5 and 9:30 schedule, and we're going to just get back to normal as quickly as possible.
Perfect.
Okay, have a good night, Ashley.
You too.
Thanks.
Okay, bye-bye. Bye.